Okay, can you all hear me
Yes, please.
and uh, and see the screen? I don't know
Yes.
why there's something called details in the center here.
I don't know,
Okay,
but I don't
right.
think it's that
Okay.
relevant.
We've had in the pathology department, we've had many inquiries regarding the use of autopsy materials for research. And so thanks to the organizers for letting me come on and talk about autopsies. I'm one of our neuropathologists and I do diagnostic work in neuropathology, both neurosurgicals and autopsies. And I've also run for many years a basic research lab in cellular and molecular neurobiology. So I wanted to talk about the autopsy in the time of COVID-19. And I started out by showing you a famous painting by Rembrandt in 1692 showing an autopsy. And what you'll see is that many of the ideas in the autopsy and the autopsy protocols really haven't changed that much in centuries. The main thing to point out in this painting is that the personal protective gear that these gentlemen are wearing is probably difficult to get today. Oops. Okay. To begin with autopsies, we have to start with dealing with the autopsy consents. And autopsy consents are not, autopsies cannot be performed without a legal consent from the patient's next of kin. And that requires a legal consent after death. Consents prior to a patient's death are not legally binding. Now, this is usually given and signed in person, but in the days of COVID-19, a lot of patients' families have not been allowed in the hospital. It's been difficult to get this rapid consent by a personal signature. I wanted to point out that the Department of Health has now allowed one of our patients' family or friends to be by the bedside in very, very serious situations. We can obtain consents by fax or email or by cell phone, assuming that the next of kin has appropriate technology. And this may not be the case for some families, but we're looking into obtaining consent by witnessed telephones. Sorry, I can't, oh, there we go. If I can do it this way. Yeah. What are the tissues we're collecting at autopsy? There are a whole series of them, as you can see, fixed and frozen, and I'll come back to that in just a minute. The organs are sampled quickly. We're going to a more rapid autopsy protocol in which we use a smaller incision and rather than taking the entire block of organs out of the body, we sample them in situ. Multiple sections are taken for fixed and frozen tissues. We've been working, Angela Saki has been working with radiology to find the most damaged areas of the lungs to sample, so we can go for those. Obviously, the things we take are going to be guided both by pathological findings and by investigators. And it also may be available fresh tissues for some protocols. And as well as autopsy tissues, we have some surgical pathology tissues, and these may include, just for example, placental tissues of mothers who are infected who give birth. And those would be available as well. How many COVID autopsies have already been performed? As of yesterday, 15, although we performed 3 yesterday. The postmortem interval ranges are unfortunately very wide. We can talk about those in a few minutes or in a discussion period. What happens to the tissues that we collect at autopsy? all the tissues go to pathology first for diagnostic purposes. And we do several things. First of all, the tissues are fixed in some of the tissues are fixed in formalin, and basically small pieces of the organs are placed in cassettes and for paraffin embedding. Paraffin sections are cut at 7 microns and placed on slides for staining to examine the general pathology. But these sections can be used for special stains, immunostains, in situ hybridization, or for a number of things that investigators may want to use them for. Tissues are also quick frozen at the autopsy in cassettes and stored at the at CUB, at the CU Biobank, that's been administered by Henning and Hipschurch for many, many years. Under some conditions, we may allow investigators to recover fresh tissue from the autopsies, depending on their needs. How will investigators ask for and receive tissues? I think the first thing to know is that all of the related research is managed through the CU Biobank. And the proposals can be sent to CUB at this website address. So send your proposals there. We're developing a committee to be ready later this week that will evaluate proposals requesting autopsy tissues and prioritize them. Please, when you send in the proposals for research, please give us details of tissue use. That is, what tissues do you need? How the tissue should be preserved, frozen, fixed, wet, in formalin, fixed, paraffin embedded. What are the thickness of the sections? How many sections? We don't want to receive protocols that ask us for things like sections of lung tissue and leave it at that. That's not useful to us. So please, please give us all the details so we can manage what we give you best. We will require that all of the data that arise from these studies be shared within the entire Columbia University community. And I put my email there for questions about any of this. And finally, do we need IRB approval to do studies? And the answer is, for the most part, no. In most cases, if specimens are released to a researcher by the tissue bank that do not include identifiers, the IRB requirements are not, IRB for this research is not required. That is, the IRB approval will be required if you request tissues that have identifiable information like patients' names or birth dates or medical record numbers. If you do, or if you want to use it for genetic testing, unless those specimens have been anonymized, we will need documentation of IRB approval before we can release such types of samples or clinical information. Okay, this has been a huge effort by many members of anatomic pathology and neuropathology, and a special thanks to these folks, Glenn and Jay and Chuck, managing the autopsy service, and Glenn being our liaison with many people, Doreen, our AP manager, who's in the middle of everything and is a wonderful person to work with, the autopsy staff, Peter and Andy in neuropathology. Ira has been our main person to help us interface with medicine. And recently, Emily, one of our cardiologists, has been instrumental in helping us get more rapid autopsy consents. And of course, Kevin, our chairman, and Mike have been really supportive of all this. And thanks again to all our organizers.
Thank you, Jim, for staying on time. In fact, a little bit faster than we expected. any question? I see one question from Andy. Andy, you want to go ahead?
Jim, thank you for this incredibly important topic. Two quick questions. One is there a protocol for handling infectious flash frozen tissue to inactivate the virus? And given the enormous incidence of cardiovascular disease, any early read on cardiac pathology?
To answer your second question first, Andy, I don't know. You can ask Chuck or Jay.
Jim, can you stop sharing so that we can get the next presenter to?
You know, how that's going. And I'm sure they'd be glad to fill you in as soon as slides are available. They would be happy to share any information that they have or show you the slides. The other issue, of course, as you bring up, is what sort of precautions do you need to take with frozen tissue? And that's an incredibly important issue. Obviously, when we deal with any human tissues, we all take universal precautions. We would like this to be done in a BSL 2 or 3 facility in a hood, and I think there are more suggestions for that on the biobank website. But yes, I think for all purposes, anyone who uses fresh frozen material or fresh tissue should simply take the point of view that there are infectious virus there. With fixed tissue, it is not. The tissue is fixed overnight and embedded in paraffin. The brains are fixed for 2 weeks before we cut them, and all of that will completely inactivate the virus.
Thank you.
Any other questions?
No, I see one question from Charles Zucker. 1 second. Charlie, should we be able to talk now?
Can you hear me now?
Yes.
Yeah, given the importance of having tissue for post-facto analysis of disease progression and effects on both tissues and organs, it seems to me that 19 subjects is a very, very small number, particularly given the spread in the post-mortem window. Now, why are we not aggressively, I understand the challenges of dealing with infected tissue and the complications associated with, getting consent and so forth. But shouldn't we aggressively pursue a strategy where we sample far more samples so that then we have the kind of biological samples that can really meaningfully add to dissecting the impact of viral infection across patient populations?
Are you talking about
your number? 19 autopsies seem to me like an unusually small number.
It is. It absolutely is, and we are
100, 150, 200. Why is that number so small?
We are very concerned about that. There are 2 issues, one of which is the autopsy consent. I think that is a major bottleneck. And Ira and Emily and some of the medicine folks have been gearing up to try to make the autopsy consents quicker and get autopsy consents.
And the law cannot be changed. The requirement cannot be changed so the consent can happen before?
No, that is against New York State and I think all state laws. That an autopsy consent prior to death is not binding. We've had over the years on the autopsy service, patient families who've given consents and then revoke their consents after the patient dies.
I see.
So that is not legally binding. I wish that would.
What about capacity? Do you have enough? Do you have enough personnel and facilities to, assuming that consent no longer becomes a barrier? Do we have the capacity to drastically increase the amount of tissue that's being
drastically? No. We have in our autopsy suite we have one negative pressure room.
Wow.
And that's where the autopsies are done. Autopsies are done from 8 in the morning. The staff is present from 8 in the morning till 8 in the evening. We do not have a 24/7 autopsy group. Most hospitals do not. But for example, we did 3 autopsies yesterday.
Yeah.
So we can do, that would probably be our maximum for the day. We are very concerned. I mean, you understand that the autopsy rate in general in this country is very, very low.
No, I get it. I get all of that. It's just that in this case,
We are trying very aggressively to get autopsy consents. Some families are very difficult to find for a whole variety of reasons.
yes.
Others don't want autopsies for, again, a whole variety of reasons. So we're trying our best, and I think the Department of Medicine, who's really at the forefront of taking care of these patients and trying to get autopsies, is really working very hard to try to increase the number of autopsies. You raise a very critical point, and we're all very concerned about it.